Chairman Hatch, Ranking Member Wyden, and members of the committee, my name is Doug Thomas. I'm the Director of the Division of Substance Abuse and Mental Health in the state of Utah, and I'm honored to be here with you today, along with these distinguished guests. Medicaid saves lives and is the backbone of the public mental health system in Utah and throughout the United States. It provides the infrastructure and economy of scale necessary for states to standardize evidence-based practices to provide high-quality care to individuals with serious mental health needs. The various Medicaid waivers and alternative benefit plans available to states allow them needed flexibility to customize plans to fit the unique challenges, needs, and resources of each state. Case management, peer support services for individuals and families, psychosocial rehabilitation, and respite services are all great examples of Medicaid reimbursable services that help people stay in their homes and communities despite serious illness and allow people the opportunity to reintegrate in place of being alienated from their families and communities of origin. In 2009, the Institute of Medicine, IOM, issued a lengthy publication about the prevention and early intervention of mental, emotional, and behavioral disorders. The report highlights that almost 1 in 5 young people have such a disorder, and at any given time, and that among adults in the United States, half of all these disorders were first diagnosed by age 14 and 3/4 by age 24. First symptoms usually precede a disorder by 2 to 4 years, giving us a window of opportunity. Narrowing the gap between the onset of symptoms and evidence-based intervention is critical, as the research is showing us that this early intervention preserves executive functioning and allows people, especially young people, and people suffering from the first episode of illness to recover more quickly with less life disruption. This allows them to accomplish and maintain important developmental tasks, such as establishing healthy interpersonal relationships, succeeding in school, and making their way into and succeeding in the workforce. For people with Medicaid, we're able to intervene early with positive outcomes, showing that people can and do recover from mental illness. Treating a person's mental illness improves physical health outcomes and reduces overall health care costs as well. There have been various Medicaid and other health system studies which show that collaborative physical and mental health care lowers costs and improves health outcomes. Prevention and early intervention can help us get upstream and bend the cost curve. In Utah 3 years ago, with a new state legislative appropriation and county matching funds, we began to act on the IOM report with what we call mental health early intervention. This consists of 3 programs: school-based behavioral health, mobile crisis outreach teams for youth in 4 of our 5 most populous counties, and family resource facilitation with wraparound to Fidelity, which is a peer support program. Over the last 3 years, we have increased services to almost 5,000 additional youth, the majority with Medicaid funding. Office disciplinary referrals are down, literacy scores are up, symptoms of mental illness are being reduced, often to the community norm, and families are receiving the supports they need to keep their children safely at home in their own school and enhancing their family's natural support system through peer support. Utah recently passed the limited Medicaid expansion, designed to target people with the lowest income in the greatest need. Parents with dependent children already on Medicaid, people who are chronically homeless, people with mental illness and substance use disorders involved in the criminal justice system, and people with mental illness and substance use disorders. We must have Medicaid work with us to find a way to approve a waiver allowing Utah to extend Medicaid coverage to those people in need. People want to be served in the safest, least restrictive environment, and providers want to provide these types of services. Sometimes children and adults need care beyond what can be provided appropriately in an outpatient or home-like setting. Allowing Medicaid residential services the ability to bill and be paid for room and board would be a great step in the right direction. Room and board is covered during a more costly inpatient hospital stay, but not covered during a more economical residential stay. This disincentivizes local, lower-cost, short-term residential services in lieu of more costly inpatient hospital care. With the Patient Protection and Affordable Care Act, the Mental Health Parity and Addiction Equity Act, and more integrated care being provided, there is a need to modernize the Medicaid Institutes for Mental Disease IMD exclusion. I applaud the efforts of the Substance Abuse and Mental Health Services Administration, Centers for Medicare and Medicaid Services, and the Department of Health and Human Services to modernize this rule, including the option of state waivers around the IMD exclusion. It must be done cautiously and systematically to ensure we are not reinstitutionalizing people, but that we are providing a short-term crisis intervention meant to help people stabilize and rejoin us in our communities where we all work and play and live. Thank you for the opportunity to testify before you today.